We're going to get into talking now about the venous hemodynamics and hydrostatic pressure. So as blood leaves the capillaries, it will enter into larger venules. The veins that are located between the capillaries and the right atrium of the heart get progressively wider, and this is going to, of course, have lower resistance to flow. The veins are like, bring me all the blood, I'll take it all the way back to the heart. The pressure in the venules is very low, about 15 millimeters of mercury, but still higher than the pressure in the right atrium, which is typically 0 to 8 millimeters of mercury. So again, we need things to go from a high pressure to the low pressure. So you can see that that's why our veins get larger when we get closer to the heart. Assuming that the person is supine, small but still significant differences in pressure is a pressure gradient. So therefore, flow can exist. But as humans, we do not lay down 24 hours a day. So when we're standing in the erect position, gravity acts on the blood in the form of hydrostatic pressure. So we have a few images here on page 125. Of course, there's some images there on page 124 as well, talking about when we're standing, hydrostatic pressure is the weight of a column of fluid from a certain reference point. Usually in the humans, we use the heart as hydrostatic pressure at 0. And I know we talked about this at the beginning of the chapter, but below the heart, the weight of the column of blood increases with the distance from the heart. Above the heart, it decreases. So looking at table 4-14, mechanism of venous return to the heart, talks about the different types of mechanisms and a nice explanation of how we get blood back to the heart for the circulation to then again go now into arterial again and keep the blood pumping through the body. But hydrostatic pressure is the reason that venous stasis ulcers are found in the ankles and not in the thighs. So let's talk about those mechanisms. And we already mentioned that a pressure gradient exists between the venules and the right atrium, and that keeps the blood moving towards the right atrium. Second, with inspiration, an area of low pressure is formed within the thorax, causing the blood to be forced into the chest. Third, venous valves, or folds of endothelial tissue inside the veins, provide a method to ensure that there's forward flow by only permitting the flow of blood in one direction to the heart. Then we have the calf muscle pump, providing that final mechanism and just kind of squeezing and allowing that blood to move towards the heart. There's not only pressure inside the veins, but outside the veins as well in the form of extrinsic pressure. Transmural pressure is the difference between the pressure inside the vein and the surrounding tissue. Low transmural pressure, which occurs when a patient is lying supine, the force outside the vein exceeds the pressure inside the vein, and the vein collapses and has this elliptical shape. You have a picture of this in your textbook on page 126. When the patient stands and the hydrostatic pressure increases, the transmural pressure increases and the vein assumes a circular shape. The veins should not be pulsatile. Now, with close proximity to the heart, they may appear to be pulsatile, but veins should be phasic or slow variations that relate to respiration. So you have pictures of this on page 126 of the phasicity of the peripheral venous form. So it should be a nice constant flow with really no kind of pulsatility. Lack of respiratory phasicity, as you see on figure 4-23b, refers to continuous flow, and this can be an indicator of some kind of intrinsic thrombus or extrinsic compression between the vein being sampled and the heart, and needs to be documented. Now, talking about pulsatility and phasicity, the arteries should be pulsatile in nature and have a distinct systole and diastole that would correspond to the flow from the heart and to the distal vascular bed. Flow is often described by the shape of its waveform on spectral Doppler, which is what you see on page 127. Usually we'll talk about this as triphasic, biphasic, or just multiphasic. Triphasic and biphasic feeds a high resistant bed, and there's typically little diastolic flow evident. Monophasic flow will feed a low resistant bed. Let's look at the pictures on page 127, and what you see on figure 4-24 is triphasic and biphasic flow, and then again you can get to monophasic. But what you see here is almost no diastole or flow. You just see systole flow, and then no flow. And this is typical in the arms and in the legs. Now look at the bottom of the page when we get into low resistance flow. Now, low resistance flow will supply the brain because we need a constant blood flow. We need the oxygen from those arteries, and we need the groceries. We need that energy for our brains to think. So again, and what you see here is you see systole, the peak flow, and then you see that flow continues through diastole. We never go to zero flow to feed a low resistant bed. Another noteworthy waveform is that if we see this, we're going to think there's some pathology present, is tardus parvus. Now this is shown to you on the top of page 128. And what tardus parvus waveforms look like is there's a delay in the upstroke of the systolic component of the waveform, meaning that there's a presence of a proximal obstruction. So most arteries have flow that initially accelerates rapidly, causing a very nice, sharp systolic upstroke. But what you're seeing here is a very slow upstroke. And so again, we need to note that, and there's probably a obstruction. With some of our patients, we're going to look at the effects of exercise on flow. In the resting patient, the peripheral lower extremity arteries are normally of high resistance due to distal arteriolar constriction. But with exercise, there's going to be an increased demand for oxygen and energy by the muscles. This is going to cause the arteriolar dilatation, which results in large diameter blood vessels and therefore a lower resistance distal bed with a corresponding increase in blood flow. In the normal patient, there is little pressure change in the distal lower extremities as a result of this dilatation. The patient with arterial obstructive disease may have normal resting pressures, but as we exercise the patient, the increased demand for oxygen that occurs may be more than the blood vessels are able to supply, causing a pressure drop distally.